And we are delighted to have Meghan Elliott from University of Calgary to talk to us about patient decision support and implications for CKD care. Dr. Elliott is an assistant professor and nephrologist at the University of Calgary. She's done her master's in Clin Epi at at UFT. She has a lot of grant funding from CIHR and Kidney Foundation, but she's also been a CRESCENT awardee, both as a postdoctoral fellow as well as a new investigator grant. Her research is mostly on qualitative work to understand patient care experiences and implement strategies to engage patients as well as providers in patient-centered CKD care, which is what we should all be doing now. So thanks, Meghan, for doing this, and please go ahead.
Thank you. And you can hear me okay, I'm assuming. Yeah. Okay, so thanks for having me today to talk on this large area around decision support and shared decision making, which is one aspect of my research program. I do not have any relevant disclosures to this talk. And I am coming to you from the territories of the People of Treaty 7 region in southern Alberta. This includes the Blackfoot Confederacy, comprising Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and Stoney Nakoda. And City of Calgary is also home to the Métis Nation of Alberta, Region 3. So these are the three objectives that I shared about the talk today. And what I hope to provide you with is an overview of what shared decision making actually means in the context of decisions related to advanced kidney disease and kidney failure. I'm going to spend a little bit of time going over decision support, also what that means and what it can look like in the context of CKD, and talk about some of the work that we have done as well as others on perspectives and barriers to implementing shared decision making in practice. A lot of the examples that I'll give today will focus on the vascular access issue, as well as planning for dialysis and choosing between kidney replacement therapy modalities. So why is this important? The average adult can make up to 35,000 decisions each day. And these are, for the vast majority of them, are minor, minimally conscious or subconscious decisions. And about 70 of these decisions are real, true decisions that actually require thought and deliberation. Now, why do I have a slide of blue and gray suits? Well, I heard an interview with Barack Obama many years ago, and he was telling the interviewer that he only wears the same gray and blue suit every day. And what he said is that I'm trying to pare down my decisions. I don't want to make decisions about what I'm eating or wearing because I have too many other important decisions to make. Decision fatigue is real. We have a lot of things that we need to decide about and act on. And the important part of this is really making sure we focus our time and effort and mental energy on the decisions that are most impactful. There are several different strategies that we can use to make decisions. On the left, there are things like impulsiveness, so taking the first option that's presented to you and running with it. Compliance, or choosing an agreeable or easy decision. Avoiding the decision or deflecting it to later. On the right, we have delegating, so assigning the decision or putting the decision in the hands of another trusted individual. Balancing involves gathering information and weighing the data to make a best decision in the moment in those circumstances. And then the last one is prioritizing and reflecting. And this is where we should be putting most of our energy, thought, and effort into the decisions that will ultimately have the greatest impact. And it's these decisions on the right that should, or these strategies, I should say, on the right that should be used when we're faced with complex decisions with potentially high impact, like kidney-related healthcare decisions. What is shared decision making? So these strategies that I'm focusing on in this talk is all centered around promoting this idea of shared decision making and decision support for people with advanced kidney disease nearing kidney failure. The term shared decision making was coined over 20 years ago by a group in the UK who did a lot of the seminal research and work to develop this area further. And in the last 15, 20 years or so, it's gained more traction in North America, and Ottawa being a hub for shared decision-making and decision support in Canada and recognized globally as well. Shared decision-making is defined as an approach where clinicians and patients share the best available evidence and where patients are supported to consider options and achieve informed preferences. Now, a lot of the shared or decision-making literature, I should say, is focused in the cognitive psychology world, which is huge and vast, and I think beyond the scope of this talk here. But I've always had an interest in the business world, and I actually think that in healthcare, we can take some pointers on how to more effectively operate in our clinical practices from the business world. Now, this is a paper from the Harvard Business Review from 50 years ago, and people still cite this even today, and it goes through the process of making an effective decision. So what we start with is the first step of classifying or characterizing the problem. What is the root of the issue that we are trying to address? Is it a generic problem, one that we see routinely, or is it a unique or exceptional circumstance that requires some lateral thinking and unique thought? Is it an individual problem, or does it affect groups and organizations at a higher level? What are the contributors to those problems and the consequences if we decide not to decide or if we delay a decision? The second step is to define what we hope to achieve and what are the potential solutions to that problem. And many solutions may or may not present themselves, and we go through each of these and decide what is not only the right decision, but what do we see as an acceptable outcome of that decision. And then we choose one of them, take actions to enact or make that decision and put it into practice. And then we come back to that and evaluate it and see how it worked out. Now, there's certainly parallels between that framework and how we make decisions in the healthcare world, but I'm going to present to you a series of rationales for why we need to expand that framework a little bit to more complex health decisions and shared decision making. So the first rationale being healthcare related decisions are numerous and complex, and arguably the stakes are higher. This is a study by Cello Tonelli from a few years ago using Alberta data, 2.5 million Albertans. And what they did is compare the complexity of patients seen by different medical specialties using these 9 different proxies for medical complexity. So number of comorbidities, number of medications, number of emergency department visits and other utilization measures, and mortality, et cetera. And when they looked at these 9 different proxies for complexity, they found that nephrologists, or they reported that nephrologists see the most complex patients. And, you know, as nephrologists, I think we can relate to this in a sense by how much we know of how complex and challenging some of our patients can be. The mean number of comorbidities of people with kidney disease is 4. The most common being hypertension, pain, ischemic heart disease. And 2% of patients with kidney disease have no other conditions, and almost 3/4 of patients have at least 3 other conditions. So it's a highly comorbid group of individuals. And not only that, the symptoms and quality of life is quite poor. We also all know this, how common these symptoms of advanced kidney disease and kidney failure present: fatigue, nausea, pruritus. And that dramatically impacts not only the burden of symptoms, but how patients perceive their quality of life and well-being. This translates into a number of decisions, and this is by no means an exhaustive list of decisions that people have to make when faced with advanced kidney disease, but deciding between medications. The average pill burden of people with advanced kidney disease is 20+ pills per day and 10+ unique medications. So compliance with medications and deciding which one of their medications they're going to take and when, whether to proceed with that coronary angiogram in advanced CKD, what to choose for kidney replacement therapy modalities, how often and how compliant you're going to be with surveillance. So there are many decision points that patients face in their kidney disease. If we apply this Harvard Business Review framework back to the idea of kidney failure, and we go through the same logic, so is it a generic or exceptional problem? Well, we might think it's generic, but certainly the patient sitting in front of you is not going to think that it's a generic problem. Is it an individual or organizational decision that people have to make? Well, yes, it's an individual decision, but not only are there group or large-scale consequences for their social circles and care team, but for society as well in general. What are the contributors and consequences of these decisions? And what are the potential solutions that might achieve the desired outcome? It's not linear. Well, it is sort of linear, but there are many layers to the decision, I guess is what I'm trying to say. Not only is it a decision between proceeding with kidney replacement therapy or conservative care, but once you commit to a certain path, there are further decisions that come after that. Do you go on to pursue a transplant or dialysis? If you choose dialysis, there's different types. If you choose hemodialysis, what type of access are you going to pursue? So at each layer of this, there are many different contributors and priorities and things that come into play that affect what feeds into the decision and what the ultimate output is going to be. I want to bring up this point about complexity not being the same as comorbidity. I think in medicine, we sometimes have a tendency to define complexity based on patient or clinical characteristics. So take, for example, two 78-year-old men who have identical health histories: coronary disease, diabetes, stage G3B CKD, and dementia. Well, the man on the left lives independently. He has family who's active in his care, help him with his ADLs, and he's financially secure. Whereas the similar man on the right lives alone, has no nearby family, is experiencing food insecurity, does not have adequate drug coverage, and struggles to get to and from appointments at grocery stores and things. I don't think anyone would dispute that the man on the right, even though for a same level of comorbidity or health burden, that the complexity of the patient on the right is greater. And so what the collaborative or shared approach to decision-making is meant to do is shift from this disease-focused to a goal-directed or priority-focused approach to patients' care and health decisions. A second rationale for collaborative decision-making is that a high degree of uncertainty exists across many of the medical decisions that we make. About 10 years ago now, there was this clinical evidence review of 3,000 different treatments, and half of them that they identified in this review had insufficient evidence to recommend for or against them. A quarter of them were thought likely to be beneficial, and then 3% of them were thought to be ineffective or harmful. Only 11% were clearly, indisputably beneficial. So for the 90% of treatments that are available, there's a great degree of uncertainty. And it's those decisions that we should focus our efforts on and weigh the risks and benefits and try to come up with more preference-focused decisions for patients. Uncertainty is the subjective perception of ignorance. So uncertainty in medicine stems from three main sources. The first is probability or risk, and that's our inability to say with certainty that someone will or will not experience an outcome. So we can't tell someone that you will be on dialysis in 2 years. You will die in 5 years. Everything is based on probabilities and risks. Ambiguity is the fact that we have inconsistent, missing, or conflicting evidence, notably in nephrology, a lack of randomized trial evidence in a lot of key areas that we need to make good medical decisions. And complexity, there's individual variability among patients, and we know that the same decision will not have the exact same outcome in 2 different individuals. So how generalizable are these principles that we're adhering to? And this leads into the idea of preference-sensitive decisions, meaning when we don't know which option is best for a person, we invoke their preferences and priorities to help tailor that to what their needs are at that given time. A good example of this is the fistula first strategy for vascular access. This was the strategy used for decades of promoting fistula use over catheters in vascular access based on the data that we had at the time. And where the uncertainty lies here is in probability is that we don't know what the success of a fistula is going to be in a person, and that it depends on both access factors and individual factors, like the characteristics of the people that are selected to go on to get a fistula. Ambiguity, so we know that there's no randomized trial evidence telling us conclusively that one type of access is superior to another, as well as complexity. It's a nuanced, complex decision with a lot of individual variation that can impact both eligibility for different access types as well as success. So a few years ago, the KDOQI clinical practice guidelines came out with a recommendation moving away from this fistula first recommendation for everyone towards the right access and the right patient at the right time for the right reasons. The third rationale is that there's a medical and a moral imperative to engage patients in decisions that ultimately affect them. We're moving away from this paternalistic approach to medicine where we simply tell a patient what's best and what to do to involving them in the care process. And I think a question that comes up is, well, how is this different from informed consent? This is what I'm doing when I'm sending my patients for testing or procedures. They both share principles of autonomy and patients retaining the decisional authority to make that call for themselves. It's also focuses on patient-centeredness. So the patient exerts control over their own care. However, with informed consent, it's an autonomous authorization. The patient authorizes us to do something or follow something or test for something. And it follows a formal process with medical legal implications. You have to discuss the intervention, alternatives, the risks and benefits, and what could happen if you don't offer that treatment. And informed consent hinges on the level of risk. In contrast, shared decision-making is an exchange of ideas. There's not a uniform formal process for it. There's no legal implications, but certainly ethical implications, I would argue. And here you discuss the intervention alongside what a person values and prefers. Whereas informed consent hinges on risk, shared decision-making hinges on uncertainty. I really like this grid that goes through different types of decisions. On the x-axis is the level of certainty, and on the y-axis is the level of risk. And so if you go to the bottom left quadrant, these are highly certain decisions that have low risk. So an example being someone develops hypokalemia while on a thiazide. I don't think anyone would argue that you should probably reduce their thiazide or stop their thiazide dose. And in this case, it doesn't really make sense to invoke informed consent or shared decision-making. You just go ahead and do it. In the top left, with high certainty decisions that are high risk, so the example they give is a gunshot wound, someone needing urgent surgery, you would try to engage in informed consent if you can, but you don't necessarily need shared decision-making in this case because there is only really one clear option to treat the patient. In the bottom right, these are low certainty decisions that are low risk. So the example here is treating dyslipidemia with lifestyle versus medications for primary prevention. You don't really need informed consent in this approach, but yes, you probably should talk about values and preferences and willingness to engage in care in a shared approach. And then it's the top right quadrant, the high risk but low certainty area that is most amenable to both informed consent and shared decision making. And I would argue that the treatments that we offer in kidney disease, the big ones anyway, would fall into this category. So when we're talking about dialysis, sending someone for a fistula surgery, offering different immunotherapies for GNs, this would fall into the informed consent plus shared decision making domain. Now, shared decision-making can bridge these communication gaps that exist between patients and providers. Sarah Davison in U of A, a while ago now, did this survey of dialysis patients, and less than 10% of them reported having had conversations with their physicians about their goals and preferences, even though 90% had wanted to. Shared decision-making can also help bridge differences in priorities and expectations. In the vascular access world, there was an international survey that showed that patients and clinicians' priorities differ related to vascular access decisions. Patients prioritize complications and involvement in their care, whereas clinicians prioritized optimizing fistula use and sustaining access. There was another interesting study where Wachterman interviewed patients about their perceived risk of mortality, what they thought their risk of dying was in the next 1 in 5 years. And then they went and talked to their clinicians, their nephrologists, and asked them the same question. And patients were much more likely to overestimate their survival compared to their predicted survival, as well as compared to their nephrologists, as well as their transplant eligibility. So these are patients who, for the most part, were at high risk of dying in the next 5 years. And 2/3 of them thought that they would be eligible to receive a transplant, whereas less than 1/3 of nephrologists thought the same. In this systematic review on shared decision-making, they looked at 105 randomized controlled trials and found that shared decision-making enhanced knowledge about options, confidence in the decisions, as well as patient involvement. And patients who are informed choose more often conservative care options. And what do I mean by that? So here's an example. In this systematic review, they found that patients who underwent shared decision-making were less likely to choose elective invasive surgery, and they were less likely to go ahead with PSA screening after having engaged in these discussions with their providers. In the kidney world, this has implications for things like dialysis selection and really relates back to the Choosing Wisely campaign, where one of the recommendations is, in fact, to not initiate dialysis without engaging in shared decision-making first, meaning it should be an individualized decision considering goals and preferences alongside patient's prognosis and the benefits and harms. However, we don't have a lot of evidence beyond that systematic review.
Okay,
There really isn't a lot of evidence on what the societal impact is on patient decision support interventions and cost savings. So in this systematic review, I guess it's a bit older now, they found that the predicted cost savings varied from $3 to $3,000 per patient who were engaging in shared decision making. However, in the studies reporting the greatest cost savings, those were the studies at highest risk of bias. So we really don't know at a societal level what the impact is beyond the individual level of increased knowledge and engagement in care. So how do we do shared decision making? It's a highly conceptual thing that we talk about a lot, but pragmatically, what do we actually do? This is adapted from the Ottawa Decision Support Framework developed by Don Stacey in Ottawa, and it was developed 20 plus years ago, and they a couple of years ago had an update to the framework. It starts with identifying needs, okay, supporting patients in understanding their knowledge and understanding their understanding of the options available to them, helping establish realistic expectations about what can be achieved, assessing patients' readiness to even engage in these types of talks, and providing support and resources. And then going into the middle section here is when we actually discuss the options. We present the different options, trade-offs, talk about people's preferences and values. And at this point is where decision support resources come into play. We classically think of things like decision aids, but this can also be personnel, individuals involved, timing and frequency of these discussions, everything to help support patients' understanding of their options, and ultimately making the decision. So having the outcome of the decision, which not only is the choice itself, but the consequences of that. Does it align with their values? Do they have decisional regret? Are they confident and happy with their decision? Do they actually enact that decision rather than just say what they're going to do? Do they actually follow through with it? Again, going back to vascular access. So this is the traditional model historically of how we approach this decision in practice. So the physician presents the evidence and makes a recommendation for a fistula. Patient either proceeds or does not with a fistula. And then you assess the functionality of that. Does it mature properly? Does it fail or not? And then repeating that cycle again with a second option. And what it's being increasingly replaced by over the last many years is a shared approach. So as we've reviewed already, it's reviewing and understanding the evidence, having high quality evidence, and then engaging in those main steps of discussing options and values and ultimately making a recommendation. But the patient retains that authority to make the decision in the end and revisit that decision again and again. This is a paper, and Swapnil was on this paper as well, but it was a qualitative study that we did looking at shared decision-making in vascular access selection among patients receiving hemodialysis. And what we found, or how we categorized our outcomes or our themes, were according to conditions that favored shared decision-making in this context or undermined shared decision-making. And what we found is that patients wanted or needed to integrate these upstream decisions. And what I mean by that is the vascular access decision is, it represents kind of the terminal decision along that treatment path. So patients really prioritized and emphasized those earlier decisions about dialysis, kidney failure. You know, how can I think about a fistula at this time when I've just been told I'm going to need dialysis? You know, there's a lot of things that weigh on people's mind before they reach that fistula catheter decision point. Really wanting that balanced exchange and from a number of different sources and perspectives, and having that opportunity to revisit these conversations again and again. This is not something that happens in one visit. It's something that they want to come back to repeatedly before and after starting dialysis. You know, even after you've started dialysis, it doesn't mean that you're done there. You should keep coming back to that. However, we all know these conditions on the right when we either can't involve shared decision making, or the outcomes are not what we had hoped. And that is when we have an unplanned dialysis initiation, maybe where we've had the discussions, but a patient hadn't come to a decision before needing dialysis, or the patient requests something or prefers something that we simply cannot accommodate. And the default in those circumstances is hemodialysis with a catheter, mainly because of timing issue, right? Like we simply cannot urgently place and get a fistula functioning. Here's a couple of quotes. One is from a patient here, said, "I don't want to go on dialysis. No one wants to. You're holding off, but you're getting to the point where you realize I'm losing this battle. So I finally agreed. It all happens quite fast." And then on the flip side, I would say that the vast majority of clinicians did feel or perceive that they were involving patients in a collaborative approach. Whether it actually panned out or not, it's really hard to say. But as one nephrologist said, I try to present the information and not direct them too much in one way or another. My job is to present the options and help them decide what they want to do. But if we look at that hierarchy or of decisions and looking at those more upstream decisions, everything related to access or any of these decisions really hinges on how patients make sense of their prognosis, how they understand the information we're communicating to them. And we are preparing or almost have finished a qualitative systematic review looking at this question, and we included 35 studies. And interestingly, of the 35 studies, only about 4, maybe 5 of them actually addressed this question of prognostic understanding as their research objective. So most of our data from this came in a roundabout way from how they presented their results related to themes of risk, et cetera. So what we found, again, perhaps unsurprisingly, is that patients have a limited understanding of their risks of kidney failure. Either it's never been discussed, or they have not retained it or internalized that. And that includes both risks of dialysis and kidney failure, but also their risks of dying or mortality risks before they ever reach that point of needing to make a decision about kidney failure. Patients in general have expectations for individualized, personalized conversations. They don't want to hear generic risks. They want to know, well, how does this information apply to me? And then I would say the central finding of this is that patients feel forced into decisions between two unappealing options. Patients equated dialysis with dying. They equated simply going on to dialysis with death, a terrible outcome that they wanted to avoid, but also not going on to dialysis was also equated with death. And so you're between a rock and a hard place, really, with these patients. And from one of these papers, in the results, they noted pre-dialysis patients articulated the benefit of dialysis was to keep themselves alive, but with an acceptable quality of life. So really, what is the cost of this decision? And then using whatever information and prognostic understanding they have to motivate action to try and mitigate risk and try and avoid these bad outcomes that they want to avoid. And also, how do they integrate some of these principles and knowledge and understanding into how they manage their day-to-day living? What are the implications for their loved ones? What kind of burden will this place on themselves and their families? So related to decision support tools and techniques, most commonly we think of decision aids, which are tools to present evidence and translate uncertainty or probabilities for patients. But decision aids are a part of, but not the only part of shared decision making. Okay, and coming back to this framework, if we focus on that decision support section in the middle, there's many pieces that can fall under there outside of decision tools like decision aids. There's conditions of the environment that you have these conversations. Who is involved? Making sure you clarify these options, assess what their needs are, what is their communication style, the health literacy. There's many things that fall into how we hold these conversations with people and how we can support those conversations. And decision aids they differ from simple educational materials or handouts in a number of ways. Most importantly, they have these specific elements and they help to personalize the information for patients so that they can make decisions at these defined time points. For the International Patient Decision Aid Standards, these are the main criteria when assessing or developing decision aids. They have to explicitly state the decision that's being considered, providing evidence-based information about the condition, options, benefits, and harms. They have to help the patient to clarify this decision in light of their values and preferences. And there has to be a formal development and evaluation process. Now, there's many, many decision aids out there. In the kidney world, there actually aren't that many, and most of them focus on this area of deciding between dialysis and conservative care or deciding between dialysis modalities. And this is one from the UK, where they clearly outline what the treatment paths are to choose from. And then the guiding questions on the left are preference-focused questions to help center the discussion. So which one of these options best suits my life? What will help me manage my symptoms and fit into my life best? And what will help me to live like I want to live? And there are several different tools and visuals that go along with this, but this is an example from the same resource of what the informational piece of this might look like. So presenting the two options, the different pathways, what's involved, and most importantly, they include the potential impacts of each of these choices. So how would this fit into your surveillance plan with your care team? What extra would be asked of you? What's the time commitment? What's the impact on quality of life. And then people can rate their pros and cons for each of these options and note questions that they want to discuss with their care team. So there's not one way to do this, but this is just one example of how you can integrate these different principles into a decision aid. And we know that decision aids can improve understanding of risk, help align values and care choices, reduce decisional conflict, and enhance communication. But there are always downsides, and we know that they can lead to longer consultations, perhaps unsurprisingly. 2.6 minutes might seem insignificant, but if you're rounding on 30 patients or you have a short time slot in clinic, that can be a big deal. And also, there have not to date been a proven benefits in terms of health outcomes, or at least measurable benefits in health outcomes. Most of these are along the domains of patient level knowledge, satisfaction, confidence, and things like that. So when we implement shared decision-making in kidney care, there's a number of barriers and challenges that we have to consider. Firstly, looking at the facilitators. So what are the things that can help us use these techniques in practice? From a systematic review in 2008, the three most important facilitators that were identified were the motivation of the healthcare provider. Perhaps unsurprisingly, you need to have a motivated care team to want to do this in order to get it into routine practice. Also, clinicians wanted to know that by doing this, it will lead to improved patient outcomes and improved care processes. So that by doing this, if I'm going to spend the extra time, I want it to make a difference. However, there are a number of barriers, starting with knowledge gaps. We've already gone over how there's a lack of high quality evidence in randomized trials in nephrology research. And until recently, there was insufficient patient-centered research as well. This has changed in recent years. We know there's a number of international organizations committed to patient-oriented research and patient-reported outcomes, CanSolve CKD being one of them, but also the SONG Initiative and the International Consortium for Health Outcomes Measurement, who are looking at redefining how we categorize outcomes from trials and nephrology studies to include patient-prioritized outcomes. And this is from the ICHOM Delphi procedure that was done a few years ago. And you can see here that the top patient prioritized outcome was health-related quality of life, but followed by in close second by patient survival. So mortality is still an important outcome to patients, but it's more just not neglecting these symptom-focused outcomes and quality of life-focused outcomes. And we know to address the knowledge gap of the lack of quality evidence in nephrology, it's getting good randomized trials out there. And I put this up as a shout out to Pietro Ravani and Rob Quinn, who I work with here in Calgary, who have been working years on getting this first feasibility trial on fistula versus catheter use in people on hemodialysis. We know that the bulk of the evidence in this area is observational and highly biased. So we really do need good quality evidence to help guide us in supporting patients' decisions in this area. And then I really like this Prepare for Kidney study. It's the randomized trial out of the UK that's randomizing folks to a conservative care responsive management pathway versus a dialysis care pathway. And so this will really help us in understanding what our options are and how we can best guide our patients. Provider factors. So there is certainly a lack of understanding on our part of what patients truly want and need. We're time constrained in our visits, and we may not have the best communication skills that we think we do. This is another study that has been accepted at the Canadian Journal of Kidney Health and Disease, where we looked at the alignment of perspectives between patients and clinicians related to vascular access choice. And everyone agreed that patients should be prepared for the decision, informed, and should really leverage that trusting relationship that we have with the care team. But there were really important and notable differences between how patients and clinicians engage in these discussions and decisions. Firstly, related to priorities, patients really wanted to minimize any disruptions to normalcy. They wanted to continue living their life and preserve whatever quality of life that they had had before dialysis, whereas the clinicians really tended to focus on how do I optimize dialysis? How do I make this most physiologically good? I think we as clinicians underestimate the influence of peer influence. Patients talked again and again about people who they knew of, or a cousin's friend, or one patient talked about how his taxi driver at one point was talking to him about how he had had an infection of his catheter, and so this patient did not want a catheter. Whereas on the clinician side of things, we spend a lot of time mitigating misinformation, because it's these negative experiences that people take away and remember more than the positive experiences with a given option. And then how we go about reviewing access. Patients, if they're happy with their access, they don't want to change, regardless of what that access is. If they're having a good go of their fistula, it's going to be hard to convince them to switch. And likewise with a catheter, most people find it convenient. If they haven't had complications, if it ain't broke, don't fix it. Whereas on the clinician side, we should make it more of a routine issue, where we routinely check in with patients and make sure they're happy and that the access is working well. And then the ultimate goal of all of this is to try and promote these strategies to bring together the perspectives and create shared decision making. There are system level factors, of course, remuneration structures and fistula targets and things like that, different metrics to capture performance, and staff training and availability for sure can also cause barriers. And then the patient factors, I think we can't underestimate the importance of these patient factors as well. Things like health literacy, the level of trust and rapport that they have with the care team, and their readiness to engage in these decisions are also all very important considerations. Now, this is to show that simply talking about patient preferences and priorities is not enough. We really do need to look at the patient in front of us and tailor how we deliver this information to their social circumstances, their health literacy, and readiness. And in patients who are from traditionally disadvantaged groups, shared decision making actually can have a strong impact on things like knowledge, self-efficacy, participation in the decision, even more so than people who are from the advantaged groups. And I want to finish with this concept here is there is a group of patients who do not want to participate in medical decisions. And I think as clinicians, we sometimes consider it a personal failure if a patient has an unplanned dialysis start, or if a person avoids or delays making the decision. But the fact is, that is a choice in and of itself. People can decide to not decide. This is a population level survey that they did many years ago, which they asked the population 3 questions. The first was, or they gave them 3 statements. The first was, I prefer to rely on my doctor's knowledge and not try to find out about my own condition. And about half of the patients agreed with that statement. So they didn't do any extra research on their own. They trusted their physician to give them the information. The second statement was, I prefer my doctor offers me choices and asks my opinion. And the vast majority of patients, even if they didn't want to look elsewhere or didn't want to make the decision, they wanted to know what their options were. And then the third one is, I prefer to leave decisions about my medical care up to my doctor. And it was almost 50% of patients who responded in the affirmative. So there is still a large subset of the population who does defer these medical decisions to their physician. And I really like this perspective in Jason from a couple of years ago, where they legitimized this option of deciding not to decide. And they provide a bit of a framework about how we can approach that in practice, and to not see this as a personal failure, but instead, how do we integrate this as an option to patients in our practice, and talking about the pros and cons of this approach, and how we can really use this to help patients exert control over their own care and autonomy. So I'm going to finish here and summarize by saying that decisions in many aspects of our kidney care are complex and uncertain. A collaborative approach to sharing information can help align decisions with patients' preferences and values, which is ultimately what we want. And that shared decision-making requires discussion and understanding about prognosis as well as patients' care goals, in addition to the specific treatment options. It's not enough just to present the treatment options, but how does that fit in to the overall picture for each patient sitting in front of us? So I will stop there, and thank you.
Thank you for that great overview of this important but difficult topic. We are, if you have questions, please raise your hand and unmute yourself. Dr. Noel is ready.
Thanks, Megan, for that talk. I just want to ask, so just to clarify, is the shared decision-making framework all based on uncertainty? So if you had a large, excellent, well-done randomized trial of fistula versus catheter with quality of life and survival benefit of one of those options that was clear, would you just move into an informed consent framework? Or do you still, even if there's good evidence, are you still in a shared decision-making framework?
I would argue that yes, you're still in a shared decision-making framework, because even with the best evidence for a treatment option, there are still values and preferences that come into that. There's issues of generalizability and patient characteristics as well. And so even with the randomized trial evidence that we desperately need, I don't think it's enough to avoid shared decision-making and just tell people that this is your option. But what it does is help inform the risks and the benefits that we talk to our patients about, so that they can integrate those more accurate estimates of outcomes as they make their decisions.
But just to follow up, like at the end of one of those slides, you had something around a mutually agreeable decision. But I think many of us, maybe it's hopefully not just me, when there's something clear cut, you don't really agree with the patient's decision sometimes.
Yes.
So is that, that's not technically following the spirit of this. So are we pretending that we're kind of doing that, or?
Yeah, that's a good point. And in our study that we did, one of our findings or themes was related to the nephrologist as gatekeepers. So even if you do engage in decision making, if the patient makes a bad choice, what you think is a bad choice, or you disagree with it, ultimately, if it's a question of vascular access, the patient may tell you what they want, but ultimately it's the nephrologist who has to put in that order, right? Mm-hmm. Who has to request the consult from the surgeon, has to proceed with the fistula creation. And then the question is, well, what do you do in that scenario? We can't accommodate every patient request if it's unreasonable. And so I'm not trying to cop out here, but I think it's a really nuanced area. And mm-hmm. in the end, the patient can make a decision, but it's up to the clinician to enact that or allow it to happen.
Yeah, no, I mean, I guess I'm thinking more on the refusal side, maybe. So situations where there's younger, healthier patients that are, refusing a transplant or mm-hmm. refusing treatment X, or refusing dialysis in those odd cases, but that you're clearly uncomfortable with that decision. I know we have to abide by it, but is that truly shared decision making when our own feeling is this is a really bad decision?
Yeah. Again, it might be that idea. It's a shared decision making process, but deciding not to decide, or the patient, mm-hmm. that idea of the patient is allowed to make a bad decision, and how can we support that? And I would argue that it still is shared decision making, and the patient is allowed to make a bad decision or a decision that you disagree with. The difficulty is when the decision requires an action versus mm-hmm. inaction, right? It's like the whole ethical principles of withholding treatment versus forcing treatment on someone. So them declining a treatment, we can justify, but you'd be hard pressed to force someone into a treatment that they do not agree with.
Yeah.
Yeah.
Thanks.
Yeah. Good discussion. Dr. Karpinski.
Yeah, thanks, Megan. I wonder if you could comment about the relationship between shared decision making and health literacy. So, like when you present that, study from Levinson that says there's, some people that prefer to leave decisions to their doctor versus make their own. Is there any has anyone looked at the health literacy of those who prefer to have their doctor make the decision versus make it on their own? Or are they related concepts or are they different? And then, what is the, how do people value shared decision making across different levels of health literacy? Because I do sometimes wonder whether with these approaches, we're privileging individuals who are already privileged. And when I look at the patient populations that we see, they tend to be not on the privileged side of the coin. And so how well some of these approaches may actually work for some of the people that we see.
Yeah, here, I'm just gonna go back. Yeah, so in this study here, actually, they did blind. I can't remember what the ages of the population was here, but what they found was that women, people who were more educated, and people who were generally healthier were more likely to take an active role. So they were the ones who were less likely to defer that decision to their physicians. And I think that's panned out elsewhere too. So folks with higher literacy, those who are less sick, maybe more supported, greater education, those are the ones who in general prefer to have a more autonomous or larger role in the decision. With I really just glossed over this one here for the sake of time, but what they did here is I think they had 19 studies in this one, and they looked at shared decision making across different disadvantaged groups, and that was mostly socioeconomic backgrounds and ethnocultural minority groups. And what they found here was even in those traditionally disadvantaged groups, they did have improvement in these aspects here with shared decision making and use of decision aids. So in the disadvantaged groups, they had improved knowledge, participation in the decision, self-efficacy. And what they found actually in the studies that include both privileged and disadvantaged groups is that the disadvantaged groups benefited more from these decision tools than those that were privileged, meaning the potential impact in these traditionally disadvantaged groups is greater. And they found that the outcomes were even greater. These tools and resources were more effective if they were tailored to that group's needs. So if you had a decision aid that was tailored to a specific group of individuals or tailored to a low health literacy group or to a specific language or ethnicity, those were the most effective decision tools.
Interesting. Peter Magner?
Decision aids. I've seen a bunch of them over time. I've seen them develop from various places. And then it seems to me they almost always aren't really actively used by a year or two later. And we developed one, and I don't think it for conservative care, and it's used for a while, mostly by the person who developed it, and then not so much since, I think. I'm not there when the nurse is doing it, but why is that? Or, there are other places I've had people tell me, oh yeah, but really we talk about all that stuff and we don't need to use the aid.
Yeah, that's a great question. And I think it speaks to the sustainability of any intervention that we try and implement and practice. With these decision aids, there's a lot of different barriers. I think one of the most important ones is the time constraint. The awareness and the time constraints, I would say, are the two biggest factors influencing sustainability. So firstly, time. We are all pressed for time. Our nurses and allied health, everyone is stretched to capacity. And so this is just one more thing. If this is one more thing that we have to add to our clinic encounter, you can forget it, right? We're trying to be as efficient as possible. So I think having these decision aids, but also streamlining them and being able to embed them within our EMRs at the point of care is a good strategy. And here in Alberta, we have recently switched over to an Epic-based system, Connect Care, that has a lot of different functionalities, and we're embedding all different sorts of clinical support tools and risk prediction tools into our EMR at the point of care. So I'm hoping that having these things right there will help. And also having the support and the personnel to support some of these things, you know, being able to print off materials, have someone review the options outside of the physician-patient encounter. There's a lot of factors that play into it.
So just to follow up on that, I frequently think that we provide too much factual information and not enough decision support. And I wish we'd spend more time perhaps with decision aids that might raise questions rather than providing a big dump of information about this kind of dialysis or whatever. Thanks.
Yeah, and to that point as well, I fully agree with you. And we spend a lot of time talking about numbers, and how we perceive risk and how patients perceive risk is also very different. We consider a 10% chance of kidney failure to be high. But if a patient looks at that and goes, well, I have a 90% chance of not getting kidney failure, you know, they're glass half full. And so I think tailoring how we give that information and framing it more around that discussion about risks and preferences, for sure.
Fantastic discussion. And Jan Davis.
Yeah, thank you for a really interesting talk. It's a subject I'm quite interested in. I think speaking to Peter's point also was part of my question, and that is, I think the part of this that we do worst on is getting patient values and goals. We're much better at providing the information, even though in our group, we very much believe in this process. And I find sometimes I do an experiment. I just say, you know, I just ask the patient, you know, what do you value and so on. I get only blank stares. So it is not something that people have any kind of past experience with being asked by their doctor, maybe only. And I've been looking recently for any kind of tool that we can use that will prompt, like, what sort of things are we looking for here? So I guess my first question is your input into how we actually do a better job of eliciting those goals and values. I have a second kind of question, which is really, we have a fair number of people, despite our very best efforts in our advanced CKD clinic, that do get to the point of dialysis without a lot of these decisions really being made firmly. And you know, such as a person who definitely wants peritoneal dialysis, like absolutely, that's the only thing that fits with their lifestyle, but they can't get around to the point of actually getting the procedure done. So here they are, they need to start dialysis and they never did do it. And I think that goes back to something I thought you put very well, and that is that we're asking them to decide always about two bad things. And they want the third option, which is that none of this is happening. And if I don't get that 2 put in my belly, then it's not happening. Anyway, I just like appreciate your comments on those things. And thank you again for the talk.
Yeah, well, thank you for those really important points. It's so hard. These are such conceptual issues, right? And we have a hard enough time convincing our patients to take a medication, let alone think of prognosis and what might happen 5 years down the road and what do they love and value. And this is what happens all the time with goals of care discussion, you know, and we all struggle with this. And I actually think the decision aids, at least the one that I presented before, is a good way of framing that. And it's not something that happens in one visit. You know, I'm not going to sit down with a patient and say, what are your priorities? And then have them spew it back to me. This is something that they take home oh, no one's ever asked me that before. You know, they take it home, they mull it over. Having tools like the one that I shared before from the UK that has a sheet, a worksheet where people can ask themselves these questions. There's blank spaces where they can jot down their thoughts and points and they bring it back to the next appointment. I think these are iterative things. And so planting the seed early is important, because I don't know about you, but when I talk about even just goals of care with my patients, oh, no one has ever asked me that before. Well, I'm asking you now, so let's get the ball rolling, right? And so I think they jot them down, they deliberate, they think about it at home, and come back, and you slowly grow over time and move towards a clear pathway. But you're right, and these are not fun and easy things to talk about. But in my experience, though, and even in our research that we've done, people are, if they have the chance to think about it, they do have priorities and values. And just thinking about the fistula question, you know, we interviewed a young guy who they wanted to put a fistula in his left arm, but he played guitar, and he said, well, I need to maintain that fine motor in my left hand for my guitar playing. So he convinced his surgeons to go over to the right arm for his fistula. So when people really do have the chance to sit and think about it, I think they can come up with some of these things with some nudging and help.
Fantastic. That was a really great discussion. Thanks again, and leaving us with a lot of food for thought. So wonderful to have you. And for those in the audience, you'll be getting an email with a survey. So please give us some feedback. Thanks, Meghan.
Yeah, thanks, everyone. Have a good day.